All right, so today we're going to talk about some unusual infections, and especially fungal infections and fungal-like organisms. So as far as fungal infections, these are the organisms we're going to talk about, so you should have some familiarity by the end with some of what these can do as far as chest pathology. So with thoracic fungal infections, the primary pathogens, so these affect immunocompetent hosts, are usually dimorphic, which means that they have mycelial and yeast forms. So in the environment, they're mold, so they have hypha spores and they're multicellular, whereas at body temperature, they convert to yeast, which means they're unicellular and they're budding. The opportunistic organisms are not dimorphic, so these are mold. So that's one way to separate these two different types of organisms. So starting with this case, what are the findings?
The top CT, multiple consolidations. There's also like a halo sign.
Yeah, what would you call this sign? I mean, here there are halo signs, right? Here's a halo. That's a reverse halo. Yeah, so that's actually a reverse halo where the inside is less denser than the surroundings. And then on the second image we have,
Air crescent.
yeah, it's a nice air crescent. So this is typical of what?
Aspergillosis.
What form? What do we call this? If it's aspergillosis, we call this angioinvasive. Yeah, so it's angioinvasive aspergillosis. This tends to affect what kind of patients? Anybody else can help while he's choking on his food? What? Yeah, what problem do they have? They're usually not asthmatic, no, immunocompromised. They're usually neutropenic patients, so acutely immunocompromised neutropenics. And again, when the white count is coming back is when we expect to see the air crescent. So that's angioinvasive aspergillosis. Nodules, masses, ground glass halos, air crescent signs on follow-up study. That's when the white count is improving. Typically, that's when you see the air crescent sign decapitation in the periphery. All right. Now, there's also airway invasive aspergillosis that can affect the more distal airways. This tends to occur in patients with AIDS, so they can have tree and bud opacities and then inflammatory changes in the distal airways. This also we've covered before. Right? Yeah. What's happening here? So here we have chest radiograph here, chest radiograph 6 years later, and CTs, corresponding CTs. What's different? Or what are the findings?
Well, there's volume loss in the left upper lobe.
Okay, so there's volume loss in the left upper lobe. Yeah, so there's volume loss. There's also inflammatory changes, right? You have regions of bronchiectasis, parenchymal opacities. The distribution of disease is mostly, well, upper or lower? Upper lobe disease, right. So when you come across a case like this, your first thought might be what?
Tuberculosis.
What?
Tuberculosis.
Yeah, absolutely. So your first thought here would be tuberculosis. But we're talking about fungal infections. So is there a particular fungal infection that might do this?
Okay, thank you.
Is the allergic pulmonary?
No, not allergic pulmonary aspergillosis, no. But since you touched on aspergillosis, what is this if this is aspergillosis? It can look like TB. Time course is protracted. It's chronic infection, upper lobe disease. What do we call this? Well, chronic necrotizing pulmonary aspergillosis, right? It was also called semi-invasive aspergillosis, or was it subacute invasive? So there are different names for this, but I think what it's called now is chronic necrotizing pulmonary aspergillosis. So this is chronic infection with aspergillosis, affects the upper lungs. You can get cavities. Mycetoma can then later on form within the cavities. And it can progress, tends to progress slowly, but essentially it's a chronic infection. Usually there is some underlying chronic problem like COPD, diabetes, etc. Okay. What's going on here? Yeah, so this is a fungus wall, right? And if it's aspergillosis, we call that an aspergilloma. So this is a fungus ball. So here, if you have a pre-existing cavity, a fungus ball can form within the pre-existing cavity. And it tends to line the cavity. You might have inflammatory changes around the cavity, but the difference here is that the cavity forms first, the fungus grows in the cavity later. The underlying diseases that can lead to cavities in which fungus balls form, what are the underlying diseases?
TB.
TB is one. What else?
COPD.
What?
Bronchitis is COPD, right?
No, not bronchiectasis for fungus balls. You don't get fungus balls in the airways.
Trauma.
Trauma? No.
Like pneumatoceal.
No. Pneumatoceles tend to resolve on their own over time.
Like COPD patient, like with a cavity.
COPD, emphysema, right? So emphysema can do it. Also, sarcoid can lead to cystic spaces in the lungs. They can also be colonized by fungus balls. Those tend to be the three most common underlying diseases. But anything that leads to a cavity can theoretically result in, at some point in the future, that being colonized by a fungus ball. Okay. Sama, you were ahead a little bit. What is this? What's the finding here?
So there's a bronchiectasis.
Right, so there's bronchiectasis, we're talking about aspergillosis. So if we have bronchiectasis like this, and we're on the topic of aspergillosis, what will this be?
Like, the diagnosis, like
What?
description or diagnosis?
What would the diagnosis be if this is bronchiectasis
So this is
involving aspergillosis? What is this called?
Is it allergic one?
This is allergic bronchopulmonary aspergillosis. So that tends to occur in what kind of patients they have underlying,
Asthmatic?
what?
The asthmatic?
Asthma, right. So underlying asthma, also cystic fibrosis, but underlying asthma is much more common, right? So bronchiectasis in an asthmatic with mucus plugging, you can't suggest allergic bronchopulmonary aspergillosis. Now, when we talk about aspergillosis and what it does, there's a nice correlation with the immune status. Severely impaired neutropenic patients, they tend to get invasive aspergillosis, airway invasive, AIDS, semi-invasive, some chronic underlying disease, COPD, diabetes. Non-invasive, they don't have to be immunosuppressed. Anything that leads to a cavity can lead to colonization with an aspergilloma, and allergic bronchopulmonary aspergillosis, those patients, asthma, they tend to be hyperimmune. Okay, so that's a nice way of organizing the information. So I give you that map. What fungus? Okay, right, so histoplasmosis. So central eastern U.S., Ohio, Mississippi, Lawrence River valleys. Bird poop, bat caves, full of histoplasmosis. And the epidemic form of exposure occurs with heavy exposure during construction, demolition, areas with contaminated droppings, chicken coops, the attics of old houses. That's the epidemic form. We'll talk about that in a little bit. You can have histoplasmosis in non-immunocompromised hosts. They can have symptomatic infection, pneumonia, and then there's acute inhalational histoplasmosis. That's the epidemic form, meaning that this is if somebody walks into like an attic or something and they inhale a large amount of organisms, they will have acute infection in the lung, and it can affect multiple people who happen to go to the same environment. And in opportunistic infection, there's chronic cavitary, which can look like tuberculosis. There, that tends to affect people with COPD, and then anybody who's immunodeficient can get disseminated histoplasmosis. They can get miliary disease. So asymptomatic infection, this can occur. Patchy pneumonic consolidation, adenopathy, kind of similar to tuberculosis. So the fungus has that in common with tuberculosis, is that adenopathy can occur in both, and both can have asymptomatic infection. And then the sites of infection in the lung can heal with granuloma formation, and if it's large enough, we call that a histoplasmoma. So a histoplasmoma is this focus of infection with a fibrous capsule, and it may develop calcification in the periphery, shell-like calcification in the periphery like that. So that can occur with histoplasmomas. Sometimes it can be lamellar, it can have layers to it as the capsule grows. They don't have to be like that. You can have, just one that looks like a granuloma with central calcification. So that can also occur. with a histoplasmoma. Pneumonia, so these patients can develop consolidations from pneumonia, usually not protracted, or there's kind of a spectrum, can be brief or can be protracted. The chest X-ray might be normal or might show consolidation with lymphadenopathy. So we can see that with histoplasmosis is another example. Consolidation here in the right upper lobe, right paratracheal lymphadenopathy. So the differential for this X-ray would be what? No, Lady Windermere doesn't give you adenopathy and right upper lobe consolidation, right? Get what the program is. What's your differential for this chest X-ray?
Tuberculosis.
Sure, certainly, tuberculosis, right? That can give you a consolidation with lymphadenopathy. What else would be in your differential? Cancer, of course, yes. Because is this atelectasis, right? Is this post-obstructive pneumonia? You do have right paratracheal lymphadenopathy. Of course, cancer also has to be the differential if you come across an X-ray like that, right? And then on CT, we can see the consolidation, we can see the lymphadenopathy, right? So consolidation with lymphadenopathy, we can see this with all fungal infections, especially with histoplasmosis. This acute inhalational form, the epidemic form, when patients are exposed to a large amount like bird droppings, in chicken coops, etc. Here the patients can develop these multifocal nodules. So very heavy exposure, high fever, severe pulmonary symptoms. Have you heard of the curse of King Tut's tomb? So the curse of King Tut's tomb, the first few people apparently who walked in there died of some mysterious febrile illness. So it's thought that that was histoplasmosis. Okay? So acute exposure to a large inoculum will lead to these multifocal kind of nodular-like consolidations or opacities in the lungs. And they can go on to heal with calcification also. Right? And so here's an example. So you have multiple kind of nodular opacities. Here's some of these have gone on to be cavitary, right? So of course your differential when you see something like this is
Bronchial spread of TB.
bronchogenic dissemination of TB. Yeah, that could be your differential. Metastatic disease, yeah, certainly, especially with cavitation, right? But when you're metastatic disease too, okay? And then it can go on to heal with multiple calcifications throughout the lungs, right? So this can be a sequela of exposure to histoplasmosis. We've gone through the differential of calcified, multiple calcified lung nodules. What are some of the things we think about there? Metastatic osteosarcoma, although you probably wouldn't mention that first. But yes, usually it's known the patient has osteosarcoma by the time that, you'll see this on the X-ray. But other things?
Varicella.
What?
You get with varicella.
Yes, sequela varicella, although there the nodules tend to be a little bit smaller than this, but they can also heal with calcification. Well, more common than histoplasmosis to give you multiple calcified nodules is just plain old tuberculosis. Okay? What can be highly suggestive of histoplasmosis? Pulmonary calcifications greater than 4 millimeters, lymph node calcifications greater than 10, and more than 5 splenic calcifications. So calcifications in the spleen associated with calcified granulomas in the lung. That can also suggest histoplasmosis, okay, as the etiology. Although, of course, you can't differentiate it from TB, which is much more common. Chronic histoplasmosis, this occurs in asthmatics. Colonization of bulla by the fungus can produce infected cavities, so they'll develop pneumonitis, and some patients can develop progressive cavitation. It can look like tuberculosis. Usually upper lobe, the infected fluid can spill into the bronchial tree and can spread to adjacent lungs. So upper lobe kind of looks like fibrocavitary disease, but in many cases what you're looking at is really infected emphysematous, the infected emphysematous bullae with histoplasmosis. And it can also develop their fluids. Right? So chronic histoplasmosis can also occur. So we're looking really at these areas of bullae that are infected with histoplasmosis, with chronic histoplasmosis. Another example, 2 months later, you can see how the fibrosis kind of progressed, looks just like tuberculosis. Okay. And then here it is on CT. So you have the upper lobe disease with architectural distortion, bronchiectasis, bullous areas, cystic spaces there. So, certainly it looks just like tuberculosis. Disseminated histoplasmosis, when there's failure of cell-mediated immunity, underlying malignancies, of course, can lead to that, or immunosuppression. And then they get miliary disease. It can also spread to other areas, the liver, spleen, lymph nodes, CNS. Looks like miliary disease. You can have bronchogenic dissemination, right? That's what we saw here, especially with the acute inhalational form. And then hematogenous dissemination gives you a miliary appearance. With this patient happened to be HIV positive, with the miliary appearance of these nodules. And the distribution of the nodules would be? Random. Yes, random distribution. Just another example. You really can't differentiate it from, the other causes of miliary nodules like tuberculosis or other fungal infections, right? So they would be in the differential. Also in the differential for random distribution of nodules besides infection is? No, that gives you intraocular septal thickening, man. No, that doesn't give you tiny nodules. Where have you guys been for the last year?
Not miliary TB.
Huh?
Miliary TB.
I said besides infection.
Hematogenous.
Yes, hematogenous what? Mets, right. What's the tumor we're supposed to think about?
Renal.
If I told you this was from a cancer, what's the underlying cancer that, any cancer can do it, of course, but the cancer you're supposed to think about is? No. Oh, it's a lost cause. Thyroid, yes, thank you. Somebody pays attention. Pulmonary histoplasmosis, complications. Let's talk about complications. Perfusion scan, ventilation scan. What's the finding on the perfusion and ventilation scan? Yes, there's no perfusion to the right lung. That's the largest mismatch you can possibly see, right? And then there on, what's the findings on the chest radiograph?
Opacification of the right lung.
What?
Like opacification, a hazy opacification of the right lung.
Some hazy opacity there in the right lung. So would you say it's alveolar or interstitial?
Alveolar?
No, I would go with interstitial. Maybe some, some prominence of the hilum. What about the volume on the right side? Looks a little bit low, right? So if we're talking about complications of histoplasmosis, you put these findings together, what do you come up with? Fibrosing mediastinitis, right. So why do we have the perfusion defect? Because what's it doing?
It's metabolism.
Pulmonary artery. Yeah. So you have a fibrotic process in the mediastinum, can be associated with calcification, and it's causing obstruction of the pulmonary artery. So why do we have the interstitial pattern here? You see the interlobular septal thickening. Why do we have that? Because of obstruction of the pulmonary vein, right. So you can have asymmetric or unilateral pulmonary edema with fibrosing mediastinitis from obstruction of the pulmonary veins on that side.
But before we see the CT chest, before we see it, can we put the BE on the differential? Or
Can you make the diagnosis on the chest radiograph and the perfusion scan? These guys did.
I mean, with the perfusion alone, you're gonna see BE, right?
What?
If you see the perfusion alone and you see the opacification on
Yeah,
the side.
okay, so you have a chest radiograph that shows unilateral abnormalities. You have a perfusion scan that shows that the right pulmonary artery is not being perfused at all. You would expect pulmonary embolism to give you, is it theoretically possible for a PE to give you like complete obstruction of just one pulmonary artery and nothing on the other side? I guess, but not very likely. But the chest radiograph does show that you have a unilateral abnormality here, right? And so trying to put the two together, this doesn't look like PE. Trying to put this with this, right, makes more sense to say there's some mediastinal process going on causing obstruction of the pulmonary artery. Neoplasm might also be in the differential, right? So neoplasm causing obstruction of the pulmonary artery. So fibrosing mediastinitis, talked about it. Another example, what's the clue? Well, you have abnormal opacity in the mediastinum, kind of has an infiltrative appearance. And the differential, of course, when you see something like this, what's the differential? Yeah, lymphoma, tumor, cancer, right? Lymphoma especially. The clue that it's fibrosing mediastinitis from histoplasmosis is what? The calcifications, right? So the calcifications are the clue that you might be dealing with infection, histoplasmosis, okay, and causing fibrosing mediastinitis. So notice here the right paratracheal opacity because of the abnormal stuff going on there in the mediastinum. What complication of histoplasmosis? Well, first, what are the findings? What are the findings on the chest radiograph? Yeah, now what's kind of interesting is this is a chest radiograph. What is this? Does anybody know what this is? Not done anymore, but that is a...
They removed the lung.
What?
It's just focused on the bone, right?
No,
Like the overexposed.
that's a tomogram. You guys heard of tomograms?
Yeah, breast.
Yeah, they used to do, you used to be able to do the same thing with chest radiographs and also abdominal radiographs, is that you were able to basically focus in on a particular plane and blur out everything anterior and posterior to that plane. So, of course, not necessary anymore. But the finding on the chest radiograph is what? Well, but what's the finding on the chest radiograph?
It's like
Follow the rules, man.
I mean, there's like a calcified.
Anybody can look ahead and spit out the answers, right? But you got to earn them. All right. What? What's the finding on the chest radiograph?
Right upper loop left.
Right upper lobe atelectasis. Yes, of course. That's all. What's all this opacity staring you in the face? That's right upper lobe atelectasis. Okay. Now in the tomogram, there is calcification. There you see it a little bit better on the tomogram, right? So calcified lymph node associated with right upper lobe atelectasis. We put that together by saying, go ahead. Broncholithiasis, right. So the lymph node erodes into the right upper lobe bronchus, causing right upper lobe atelectasis. So that's broncholithiasis. In addition to histoplasmosis, what else can give you broncholithiasis? TB, of course, tuberculosis, right. Okay, so that's broncholithiasis. This we've covered already. That is called a histoplasmoma, right. It's got that ring-like peripheral calcification. Occasionally TB can do that too. So it's not exclusive to histoplasmosis. There's a very nice appearance with those shells, the laminated appearance of the different layers as they grow. Okay, so we can get that with histoplasmomas. Sometimes they're non-calcified, right? In which case it just looks like a nodule, non-specific, exactly. It looks like a cancer, right? So that can happen. Here we have necrotic lymph nodes, and that can also occur with histoplasmosis. These are called mediastinal granulomas. So they're necrotic. When they go on to heal after treatment, then the central low attenuation can go away. All right, so that's mediastinal granuloma. And then here's an example showing the lymph nodes impressing on the esophagus. Okay. So those are the complications of histoplasmosis, right? This is a 65-year-old man. The findings on the chest radiograph. Yeah, well, there's funny-looking opacity there in the left lower lobe. Anything else? Right, so you're wondering about that mediastinum. There's a little bit too much stuff there. Maybe that's lymphadenopathy. There's all these opacities here that are hard to explain. What are we going to do? Yeah. Well, first we look at. First thing we do is look at old films, right? Yeah, of course, we're going to go to CT here. All right, so here's our CT. Now what do we have? Right, so there's mostly on the left side, right, where we have these like nodular opacities. This one looks like a mass, okay? And there's a little bit of history I withheld from you, and if you're sharp enough, you might be able to tell me what that is.
Just like a big spleen of varices.
You can do better, but you're on the right track. What's the history I withheld?
Lymphoma.
In this hospital, it's a shame if you can't tell me the history I've withheld from you.
Liver transplant.
Liver transplant. Look, that stuff, right? Around the IVC, this patient has had a liver transplant, okay? What does that tell us about the patient? Immunocompromised, right? So this means now all bets are off. There are a lot of crazy things we have to start thinking about here, right? So what else happens? Well, this happens, right? So what do we see on the MR?
Yes, sir. Occipital.
There are lesions, right? You see the ring, some of these are ring enhancing, right? So we have these lesions in the brain. So what fungal infection can affect immunosuppressed patients, but also disseminate to the brain?
Histoplasm. Histo?
I hear a lot of mumbling. Nocardia is not a bad choice. So that certainly is possible, yes.
Like histoplasm can do that, right?
Hmm?
Histoplasma can.
Well, theoretically, any fungus can do it, right? But there's a particular fungus that is notorious. So Cryptococcus, okay? So worldwide, inhaled, deposited in the lungs. If cell-mediated immunity is impaired, you get chronic pulmonary infection and hematogenous dissemination. This form is predominant in the Pacific Northwest, but it can especially spread to the brain, meningitis, meningoencephalitis, most serious consequences of extrathoracic spread. So you could have nodules, consolidations, disseminated disease, rare in the normal host, though dissemination more common in immunocompromised patients. And there, of course, you can get a biliary pattern with it. So pulmonary nodules are masses, the most common finding, completely nonspecific, right? Any of the fungal infections can do this, okay? But, again, if you come across that case of an immunosuppressed patient with multiple nodules, don't forget about fungal infections. Can do this stuff. More examples, these can look like tumor, right? Especially in the subpleural region like that, can look like tumor. Multifocal areas of infection with Cryptococcus can cavitate, like you see here, examples of cavitation, right? So we can also see that. Immunocompromised patients, AIDS, hematologic malignancies, organ transplants, steroid therapy, greater tendency for cavitation, adenopathy, effusion, disseminated disease, CNS, especially meningitis, is the most common extrathoracic site of dissemination with Cryptococcus, okay? So in immunocompromised patients, again, much the same, nodules, consolidations, lymph nodes, disseminated disease, miliary disease, of course you can see that also. So very similar appearance, multiple opacities, looking like nodules and masses. Miliary disease looks like all the other miliary diseases that we've seen. Small tiny nodules scattered throughout the lungs. This is a patient with AIDS, as it turns out. What fungus? All right, so that we're talking about the desert climates there, right? So here we're talking about, I can't even spell it, let alone pronounce it, Cymiotomycosis, right? So tends to occur in desert climates associated with earthquakes. That tends to raise a lot of dust and have it transmitted throughout the atmosphere, and then you can get kind of this epidemic form of infection with that, right? So patients can have asymptomatic infection. It can heal with a granuloma or calcification. And then, of course, you can also have symptomatic infections with, there's a primary form, chronic form, disseminated infections can also occur. Primary mild viral infection called valley fever. And then, of course, all the things you would expect, consolidations, nodular opacities, lymphadenopathy, pleural effusions. So nothing terribly specific, any of these things can happen. So here's an example with consolidation there in the right upper lobe. Also here going to the right lower lobe in this patient. And they may or may not have lymphadenopathy, multiple nodules, right? So fungal infection, not a bad thing to include in your differential of multiple nodules, especially in immunosuppressed patients. Pleural, here's an example with nodule, pleural effusion, this particular patient. And lymphadenopathy. All fungal infections, just like TB, can result in lymphadenopathy. Okay? Chronic infection can also occur, so if it persists for more than 6 to 8 weeks, so they can develop nodules, they can develop granulomas with central necrosis, they can develop single or multiple lesions, and so just like you can have a nodule from histoplasmosis, you can also have a nodule from coccidia. Right? So that nodule turned out to be from coccidia. And then you can have cavitary infections. Now, what can occur with the cavitary form is that when it goes on to heal, you can be left with a very thin-walled cavity. Looks like a nematocele. So that's the classic sequela of this. So it starts out as an infection. You can get cavitation like that. And then when it heals, as it heals, you can be left with a thin-walled cavity. All right, so that can occur as a complication of this. And here's a nice example of showing you. Starts out as a consolidation, cavitary, forms a nodule with cavitation, and then goes on to heal as this thin-walled cavity. Okay? So that's particular to this organism. Another nice example. Thin-walled cavity as a sequela of infection. And then with chronic infection, lymph nodes, pneumonia, fusions, end-stage disease can also occur in some patients. And then, sometimes it can look like TB also, if it tends to affect the upper lobes. So this patient has immunosuppression with SLE, leads to those findings. So disseminated disease can also occur. Again, any form of immunosuppression. Also pregnancy. Pregnancy is associated with disseminated coccidia. And so that looks like biliary disease for everything else. Multiple random nodules. What fungus?
Blastome.
Yes, one left. So blastome. So endemic areas outlined there. And so it's found in moist soil, wooded areas. Pulmonary infection here can disseminate to extrathoracic sites. So skin, bone, especially the bone, and then these other areas. Subcutaneous abscesses grow to become skin ulcerations, common manifestation of this infection. So patients can have consolidations, can have masses. It can look like lung cancer. It can have lymphadenopathy. But as far as the bone, they can also get osteomyelitis. So this is the fungus where you could have lung lesions with bone lesions with osteomyelitis. So I guess it could look like metastatic disease to bone too. Disseminated disease, of course, gives you a biliary pattern. So consolidation, right? So nonspecific appearance there of infection within the lung. Things that look like masses. Here we have some bronchograms in this particular case. It can mimic lung cancer. Cavitary lesions can occur with any of these infections. But what's peculiar about this is involvement of bone. You can get lytic lesions in the bone from osteomyelitis. You can see the rib there and the tibia also in this patient. So it looks like another lesion there too, subcutaneous lesion. There's another example, lesion in the lung, and then affecting spread to the bones. So bone lesions from osteomyelitis with blastomycosis. Skin lesion with ulceration, blastomycosis. And disseminated disease gives you a biliary pattern, just like all the others. So, I've given you the article that goes through all of this and the geographic distributions of the different infections. So let's talk about a few more types of infections. So pulmonary mucormycosis. So this is opportunistic. These are molds, so they're found all over the environment. So the predisposing factor here is going to be some underlying immune problem. So defect in macrophage or neutrophil function. Hematologic malignancy, diabetes, especially diabetics, unable to inhibit the growth of spores. So diabetics are prone to these mold infections, these mucormycoses, and then chronic renal failure also. Okay? And so these patients can develop, infection is fatal if untreated with these, probably because of the underlying problems that the patient has. The fungus can invade pulmonary vessels, can have single or multiple form infection, can look like aspergillosis, invasive aspergillosis, where there are crescent formation, okay? Cavitation from infarction, just like invasive aspergillosis. So pulmonary mucormycosis, think about this if you have funny looking lesions in a patient who's diabetic. This is a patient who's had a renal transplant. So we have a cavitary lesion in the lung, ring enhancing lesion there in the brain. Now, if this is, actually, is there one or more than one lesion in the lung? Yeah, there's more than one. If this is the only information that you had, your first choice here would be what? What's it?
Maybe septic embolism.
That's too thick to be septic embolism, right?
Like TB.
Lung cancer, right? So lung cancer with metastases would probably be your first choice, okay? But here we're talking about unusual infections, and I'm giving you the history of renal transplant. So renal transplant with pulmonary infection and brain abscess. Yep, no cardiosis. Right, so predisposing factors, immunosuppressive therapy, organ transplants, AIDS or other immunodeficiency. Interestingly, alveolar pronosis. Those patients are also prone to infection with no cardiosis. So here, consolidations that frequently cavitate, single or multiple round pneumonias, and this can disseminate to the brain and give you brain abscesses. So that's what's peculiar about no cardiosis. Right, so it can cavitate, form thick-walled abscesses, and can disseminate to the brain. Okay. So this patient was HIV positive, and where is this mass located? Now obviously from the lateral it helps, right? There it is in the anterior mediastinum. Can you tell from the frontal, what are the clues on the frontal that it's in the anterior mediastinum? Okay, so you have a hilum overlay sign, right? So you can see the pulmonary artery through the mass, but what does the hilum overlay sign tell you about the location of the mass? That it's not in the middle, so it's either anterior or posterior. So how do you nail it down to being anterior?
Posterior vertebral line is intact.
So, posterior, but better than the posterior vertebral line, you can see what?
Aorta.
Yeah, the descending thoracic aorta. And what is obscured by the mass? The heart border. The left superior heart border, the heart's more anteriorly located within the chest, right? So this is a big anterior mediastinal mass here, and it's invading into the chest wall. And is this the only focus of disease? No, there are others, right? So you have these cavitary lesions in the lungs. So this was a patient with AIDS. This was also no cardiosis. Okay, so no cardiosis can affect patients with AIDS. It can give you masses like this that can also invade the chest wall.
So that's not empyema necessitans, it's like...
So empyema, all right, so for empyema necessitans, right, the first part of that word is, right, so you have to have empyema. Right? Do you think, does this patient look like they have empyema?
I mean, I'm obliged to say no, but...
Well, what part of this looks like empyema?
I mean, it looks like it could be like a fluid collection, like a fluid collection.
Well, yeah, but is that in the pleural space?
No, it's not. Yeah.
Right. So that's in the mediastinum, okay, and extending into the chest wall, right? So that's not really in the pleural space, okay? This is an 18-year-old with chest pain. So I'm showing you the chest X-ray that shows this obvious large opacity in the right upper lobe, and then pre and post-SCAD images there. Actually, both of them look like they're post-SCAD. Sorry about that. So what can we say about this thing? What's it doing? It's enhancing. What else?
Is it like in the lung or in the mediastinum?
Well, first, is this lung or mediastinum here? That's lung, right? So that's in the lung, okay? What about the soft tissues? Yeah, so the soft tissues are normal too, right? So your first thought here might be what? If you have a mass in the lung that invades through the chest wall, you're thinking what? Cancer, right? So you're thinking some kind of malignancy, okay? But if we're talking about infections, right? What is the infection, or what infections can involve the lung and can extend through the chest wall into the soft tissues? What are the infections that do that? TB, of course. What else? What? Not blasto, but I mean, theoretically, it is possible for any fungal infection, even aspergillosis. It is possible for those to do that, so they can involve the chest wall. But the classic infection to involve the lung and extend to the chest wall is actinomycosis, right? Actinomycosis. Okay, because it causes sinus tracts and it's very destructive. So it can spread very easily beyond the lung into the chest wall. And we've seen an example of nocardiosis also that can do that, but that's usually immunosuppressed patients. In immunocompetent patients, tuberculosis and actinomycosis. Right, so sulfur granules, that's the thing that you're supposed to look for. Proteolytic enzymes that allows the infection to cross fascial planes, resulting in pneumonia, empyema, abscesses, sinus tracts, and bone destruction. So actinomycosis, this can be aspirated, so this organism can extend through the lungs into the chest wall. Consolidations are masses that cavitate. You can get that with actinocavitary lesions, like you see here, just like with everything else we talked about. And then you can get empyema, and it can extend rib destruction, bone destruction, as it extends to the chest wall. So if you have a process that involves the lung and extends into the chest wall, in addition to malignancy, you can also consider infections like TB and actinomycosis. So what are the things to remember? So it helps to remember what's going to be different about each of these, because if you're preparing for an exam, that's where the questions are going to come. All right? So histo, asymptomatic infection, most common, acute infections, small inoculum, pneumonia plus or minus nodes, large inoculum, nodules that can calcify, the epidemic form that we talked about. Chronic infection associated with COPD, disseminated infection, like everything else, gives you a miliary pattern. The complications to know: histoplasmoma, fibrosing mediastinitis, bronchodithiasis, mediastinal granuloma. Crypto can affect patients with AIDS, patients who are immunosuppressed, pulmonary infection, meningitis. The CNS, very common extrathoracic site of spread for crypto. Coccidio, the classic lesion, the sequela is a thin-walled cavitary lesion. Blasto can mimic lung cancer, bone lesions. This one is associated with osteomyelitis. And in mucormycosis, usually immunocompromised patients, resembles invasive aspergillosis. Nocardiosis, immunocompromised patients may disseminate to brain. Actinomycosis, lung that involves the chest wall. So we have a lung lesion, we have a bone lesion, we're thinking blasto, right? And then blasto can also look like lung cancer, can be peripheral in the lung, it can look like lung cancer, so that can do that. This, which fungal infection? Coccidio, the thin-walled cavitary lesion, right? Because calcification, and what process are we going to be concerned about here? Fibrosing mediastinitis if it's histoplasmosis infection. Okay? Here, yeah, so here you've got brain lesion, you've got brain abscesses here if we're talking about infection, and you have something, something in the lung, so nocardiosis, right? So that